You walked into your doctor's office last month for what you thought was a routine checkup. Maybe you had a minor complaint. Maybe you just needed a prescription refill. And then your doctor said those words that sound so responsible, so medically prudent. At your age, we should probably run some tests, just to be safe. And because you trust your doctor, because you want to be proactive about your health, because catching problems early sounds like common sense, you said yes. You scheduled the tests, you went through the procedures, and now you're dealing with something you never expected. Not a diagnosis, not a treatment, but a cascade of follow-up tests, specialist referrals, anxiety-filled waiting rooms, and medical interventions for problems that may never have caused you a single day of trouble in your entire life. Here's what almost nobody tells you, and what the medical establishment is deeply uncomfortable admitting. After age 65, some of the most commonly ordered medical tests do more harm than good. Not because the tests themselves are dangerous, though some are, but because of what happens after a positive result. The anxiety, the follow-up procedures, the overtreatment of conditions that would never have shortened your life or reduced your quality of living. My name is Dr. Michael Carter, and over the past 15 years working with patients in their late 60s, 70s, and 80s, I've watched the same pattern repeat hundreds of times. A well-intentioned screening test finds something small, something ambiguous, something that technically qualifies as abnormal, and suddenly a healthy, active senior is thrust into the medical system, undergoing procedures with real risks to address findings of questionable significance. A comprehensive study published in JAMA Internal Medicine analyzed over 30,000 patients aged 65 and older who underwent routine screening tests. The researchers found that nearly 60% of these patients experienced at least one downstream harm: anxiety, unnecessary biopsy, surgical complications, or overtreatment of clinically insignificant findings without any measurable improvement in lifespan or quality of life. 60%. That's not a small minority. That's the majority of people being harmed by tests designed to help them. So in the next 23 minutes, I'm going to walk you through 5 medical tests that are routinely offered to people over 65, and I'm going to explain exactly why the risks often outweigh the benefits. Then I'm going to give you the specific questions you need to ask your doctor before agreeing to any screening test, because that conversation could be the difference between aging gracefully and spending your retirement navigating the medical system unnecessarily. Let me give you the framework that's going to make everything else in this video make sense, because there's a fundamental shift that happens in medical decision-making after age 65 that almost nobody explains clearly. When you're 45 or 50, screening tests make tremendous sense. You find a small cancer early, you treat it, you potentially add decades to your life. You catch high cholesterol, you manage it, you prevent a heart attack at 58. The math works. The benefit is clear. You have 30, 40, maybe 50 years of life ahead of you to benefit from early detection. But here's what changes after 65, and I need you to hear this carefully, because your doctor may never frame it this way. First, your life expectancy timeline compresses, not in a morbid way, just mathematically. If you're 68 years old, your statistical life expectancy might be another 15 to 20 years. That's still a beautiful, meaningful stretch of time, but it's different from 40 years. And that difference matters tremendously when we're talking about screening for slow-growing diseases. Second, your body's relationship with disease changes. Many cancers that grow aggressively in a 50-year-old grow very slowly in a 75-year-old. Some don't grow at all. They just sit there, dormant, never causing symptoms, never spreading, never threatening your life. Doctors call this overdiagnosis, finding a disease that meets the technical definition of cancer or illness, but will never actually harm you. Third, and this is critical, your risk tolerance for medical procedures changes. A 50-year-old can bounce back from surgery relatively easily. A 72-year-old faces significantly higher risks of complications, infections, delirium, functional decline, and prolonged recovery periods. What's a minor procedure for a younger person becomes a major health event for an older adult. And fourth, there's something researchers call competing risks. If you're 78 years old and we find a tiny prostate cancer that might become problematic in 15 years, but you also have heart disease, diabetes, and kidney function that's declining, the statistical reality is that something else is far more likely to affect your lifespan than that slow-growing prostate cancer. This is the concept that the medical system struggles with. We're trained to find problems and fix them. We're not trained to find problems and leave them alone. even when leaving them alone is the wisest choice. The U.S. Preventive Services Task Force, the gold standard organization that issues screening guidelines, has become increasingly conservative about recommending tests for older adults, not because they don't care about seniors, but because the evidence shows that after a certain age, many screening tests cause more harm than benefit. And yet, those guidelines are often ignored. Tests are ordered out of habit, out of fear of lawsuits, out of genuine but misguided desire to do something, even when doing nothing would serve the patient better. That's the lens I want you to carry into everything that follows. Let's start with the category of tests that generates the most controversy and the most emotional resistance when I suggest they might not be necessary. Cancer screening. I'm going to say something that might shock you. If you are over 75 years old, have a life expectancy of less than 10 years due to other health conditions, and you have no symptoms, routine screening for prostate cancer, breast cancer, or colon cancer may cause you more harm than benefit. Let me be very clear about what I am and am not saying. I am not saying cancer doesn't matter. I am not saying we should ignore symptoms. I am absolutely not saying that if you find a lump, see blood in your stool, or experience unexplained weight loss, you shouldn't get evaluated. What I am saying is that looking for cancer when you feel perfectly fine, when you have no symptoms, when you have other health conditions that are more likely to affect your lifespan, often leads to a cascade of harm without meaningful benefit. Let's start with prostate cancer screening using the PSA test. Prostate cancer is incredibly common in older men. Autopsy studies have shown that by age 80, more than 50% of men have some prostate cancer cells present. But here's the critical point. The vast majority of those cancers will never cause symptoms, never spread, and never threaten life. The problem is, once you do a PSA test and it comes back elevated, the system kicks into gear. You get referred to a urologist, you undergo a prostate biopsy, a procedure that carries risks of infection, bleeding, and hospitalization. The biopsy finds cancer because at your age, it probably will. And now you and your doctor are faced with a terrible dilemma. Do you treat this cancer aggressively with surgery or radiation, procedures that carry significant risks of incontinence, impotence, and bowel dysfunction? Or do you choose active surveillance, which means living with the knowledge that you have cancer and doing nothing about it, an emotionally unbearable situation for many people? A landmark study published in the New England Journal of Medicine followed over 76,000 men for 13 years. Half received regular PSA screening, half did not. The result? No difference in prostate cancer mortality between the two groups, but the screened group had significantly higher rates of biopsies, surgeries, incontinence, and sexual dysfunction. No survival benefit. Substantial harm. The U.S. Preventive Services Task Force now recommends against routine PSA screening for men over 70 because the harms outweigh the benefits. The same principle applies to mammography screening for breast cancer after age 75. Breast cancer found on a mammogram in a 78-year-old woman with diabetes and heart disease is statistically unlikely to be the thing that shortens her life. But the biopsy, the lumpectomy, the radiation, those interventions carry real risks and real side effects. Research published in JAMA Oncology found that women over 75 with limited life expectancy who underwent breast cancer screening were more likely to die from complications of treatment than from the breast cancer itself. Let me repeat that. More likely to die from the treatment than the disease. And colon cancer screening with colonoscopy after age 75 carries its own set of risks. Colonoscopy is an invasive procedure. It requires sedation. It requires bowel preparation that can cause dehydration and electrolyte imbalances, particularly dangerous in older adults. And the procedure itself carries a small but real risk of perforation, bleeding, and cardiovascular events. If you're 77, you've had normal colonoscopies your whole life, and you have no family history of colon cancer, the chance of finding a life-threatening cancer that will manifest in your remaining lifespan is extremely small, but the chance of having a complication from the procedure is real. Here's the symptom pattern that should make you question whether screening is right for you. You have no symptoms. You have other chronic health conditions that limit your life expectancy. You've had prior normal screenings. And most importantly, if cancer were found, you're not sure you'd want aggressive treatment given your age and health status. If that describes you, it's time to have a very honest conversation with your doctor about whether continued screening makes sense. Here's what you say: given my age, my other health conditions, and my personal preferences, what is the actual likelihood that this screening test will extend my life in a meaningful way, and what are the risks of harm from the test and any follow-up procedures? That question forces your doctor to think beyond the reflex, to screen everyone, and actually personalize the recommendation to you. Here's one that sounds so sensible, so preventive, that most people never question it. Your doctor says, let's do an EKG just to check your heart, and maybe a stress test to make sure everything's okay. You have no chest pain, no shortness of breath, no palpitations. You feel fine. But it's for prevention, right? It's catching problems early. Except here's what actually happens. You go in for a routine EKG. The machine spits out a reading. The computer interpretation flags something as abnormal, maybe a minor ST segment change, maybe a slightly prolonged QT interval. Maybe a finding that's completely normal for your age but looks different from textbook normal. Now, your doctor is concerned, not because you have symptoms, not because you've had a cardiac event, but because a test result is flagged. So you're sent for a stress test. You walk on a treadmill while hooked up to monitors. Your heart rate goes up. The test shows some minor abnormality, maybe decreased blood flow to one area of your heart during peak exertion. Now you're sent to a cardiologist. The cardiologist recommends a cardiac catheterization, an invasive procedure where a tube is threaded through your blood vessels to your heart to look for blockages. The catheterization finds some plaque. Not a complete blockage, not something causing symptoms, just some atherosclerosis, which frankly, almost everyone over 65 has to some degree. But now that it's been found, it has to be addressed. You're put on 3 new medications. Or maybe you undergo a stent placement, a procedure with risks of bleeding, kidney damage, stroke, and heart attack. And here's the kicker. You never had symptoms in the first place. You felt fine. You were living your life. And now you're a cardiac patient, taking medications with side effects, undergoing procedures with risks, all because of a screening test you didn't need. A study published in the Archives of Internal Medicine examined over 5,000 asymptomatic adults who underwent routine cardiac screening. Those who had abnormal findings and subsequent interventions had no improvement in cardiovascular outcomes compared to those who weren't screened, but they had significantly higher rates of procedural complications and anxiety. The American College of Cardiology and the American Heart Association both recommend against routine EKG or stress testing in asymptomatic adults, regardless of age, because the evidence shows no benefit and substantial potential for harm. Here's the critical distinction. If you have symptoms, chest pain, shortness of breath, dizziness, palpitations, absolutely get tested. Symptoms change everything, but if you feel fine, screening your heart with EKG or stress testing is far more likely to start a cascade of interventions than it is to prevent a heart attack. Here's the pattern that should make you refuse this test. You have no cardiac symptoms. You have no family history of sudden cardiac death at a young age. You're not planning to start an intense new exercise program, and your doctor is ordering the test just to be thorough. That's not thorough. That's practicing defensive medicine, and you're the one who pays the price. Here's what you say to your doctor. I understand you're recommending this test, but I have no cardiac symptoms. Can you explain what specific outcome this test is trying to prevent and what the false positive rate is for my age group? That question makes your doctor pause and actually think about whether the test is evidence-based or just routine. Let's talk about bone density testing, specifically the DEXA scan, and why continuing to get this test after you've had multiple normal results may not be helping you. Bone density screening makes perfect sense for women in their early 60s. Osteoporosis is real. Fractures are serious. Catching bone loss early and treating it with medication or lifestyle changes can prevent devastating hip or spine fractures. But here's what happens in practice. You get a DEXA scan at 62. It's normal. You get another one at 65. Still normal. You get another at 68. Normal again. You get another at 72. Still normal. At what point does repeating this test stop adding value and start becoming a waste of time, resources, and in some cases, a source of unnecessary treatment? If you've had multiple normal bone density tests, if you're not on medications that affect bone health like long-term steroids, if you have no history of fractures, and if you're already doing the things that protect bone health, weight-bearing exercise, adequate calcium and vitamin D, not smoking, the likelihood that your next DEXA scan is going to suddenly reveal severe osteoporosis is extremely low. But here's what does happen. You get one more DEXA scan. This time, it shows osteopenia, not full osteoporosis, but lower than ideal bone density. It's a borderline finding. Maybe it's real. Maybe it's just normal age-related change. Maybe it's measurement variability between machines. But now your doctor is concerned. You're started on a bisphosphonate medication like alendronate. These medications do reduce fracture risk in people with true osteoporosis, but they also have side effects: esophageal irritation, jawbone necrosis in rare cases, and atypical femur fractures with long-term use. And here's the question nobody asks. If you've had normal bone density for a decade and you're already doing everything right, is the marginal benefit of medication worth the risk and cost? A study published in the Journal of Bone and Mineral Research followed over 4,000 women with normal baseline bone density. Repeat screening within 5 years identified only 1% who had progressed to osteoporosis requiring treatment. The authors concluded that for women with normal bone density and no risk factors, rescreening intervals could safely be extended to 10 to 15 years. 10 to 15 years, not every 2 years, not annually. Here's the other piece that frustrates me. Bone density is only one piece of fracture risk. Your balance, your muscle strength, your home environment, whether you have throw rugs or poor lighting, these factors often matter more than bone density numbers. I'd rather see a 72-year-old woman with osteopenia who does balance exercises 3 times a week and has excellent lighting and grab bars in her home than a woman with normal bone density who's sedentary and lives in a house full of trip hazards. Here's the pattern that should make you question whether you need another DEXA scan. You've had multiple normal results. You've never had a fracture. You're already taking calcium and vitamin D. You do regular weight-bearing exercise. And you're not on any medications that weaken bones. If that's you, you can probably skip the next DEXA scan and focus your energy on fall prevention instead. Here's what you say to your doctor. I've had 3 normal DEXA scans in the past decade. Given that my bone density has been stable and I'm already doing everything recommended for bone health, is there evidence that another scan right now will change my management in any meaningful way? That question refocuses the conversation on what actually matters, your fracture risk, not just a number on a scan. This one is subtle, and it catches a lot of people off guard because thyroid problems are real, and thyroid testing seems so simple. Just a blood test. What's the harm? Here's the harm. You go in for routine labs. Your doctor orders a comprehensive panel. Included in that panel is a TSH, thyroid-stimulating hormone, the screening test for thyroid function. Your TSH comes back slightly elevated, not dramatically high, just a bit above the normal range. You have no symptoms. You don't feel tired. You haven't gained weight. Your hair isn't falling out. You feel completely normal, but the number is abnormal. So your doctor diagnoses you with subclinical hypothyroidism and starts you on levothyroxine, synthetic thyroid hormone. Now you're on a medication you'll take every day for the rest of your life. You need blood tests every 6 months to monitor levels. You need dose adjustments. And here's the part that almost nobody tells you, the evidence that treating subclinical hypothyroidism in older adults improves any meaningful outcome is extremely weak. A landmark study published in the New England Journal of Medicine randomized over 700 adults aged 65 and older with subclinical hypothyroidism to either thyroid hormone treatment or placebo. After 12 months, there was no difference between the groups in quality of life, energy levels, cognitive function, or cardiovascular outcomes. No difference. None. But the treated group had higher rates of atrial fibrillation and bone loss, both potential side effects of thyroid hormone over replacement. Here's what's actually happening in many of these cases. TSH levels naturally rise slightly with age. What's abnormal for a 40-year-old might be completely normal for a 75-year-old. But lab ranges don't adjust for age, so older adults get flagged as abnormal and treated unnecessarily. The other thing that happens is transient TSH elevations. You had a viral illness. You were under stress. You were taking a medication that temporarily affected thyroid function. Your TSH was checked at that moment, came back high, and now you're being treated for a problem that would have resolved on its own. Here's the pattern that should make you question thyroid treatment. Your TSH is only mildly elevated, less than 10. You have no symptoms of hypothyroidism. Your cholesterol is normal. Your heart rate is normal. And this is the first time it's ever been checked or the first time it's been abnormal. In that scenario, the right move is often to recheck the level in 6 to 8 weeks, not to immediately start medication. Here's what you say to your doctor. I understand my TSH is slightly elevated, but I have no symptoms. Before starting lifelong medication, can we recheck this in 2 months to see if it's persistent? And can you show me evidence that treating subclinical hypothyroidism at my age improves outcomes? That question challenges the reflexive treat the number approach and refocuses on whether treatment actually helps you. Now we're getting into territory that genuinely concerns me because this is where profit motive intersects with medical decision-making in ways that are rarely in the patient's best interest. You've probably seen the ads. Executive health screening. Full-body CT scan. Catch disease before symptoms appear. The most comprehensive physical you've ever had. It sounds appealing. It sounds proactive. You pay a few $1,000s, you spend a day getting every test imaginable. CT scans of your chest, abdomen, pelvis, cardiac calcium scoring, carotid ultrasounds, extensive blood work, and at the end, you get a beautiful bound report telling you everything that was found. Here's the problem. When you go looking for abnormalities with that level of detail in a human body that's been alive for 70 years, you will find abnormalities. Guaranteed. You'll find a small nodule in your lung. Probably benign. Probably been there for years. But now that it's been seen, it has to be followed. So you're getting chest CTs every 6 months, accumulating radiation exposure, living with anxiety, possibly undergoing biopsy. You'll find a cyst in your kidney. Almost certainly benign. Almost everyone over 60 has renal cysts, but now you need follow-up imaging, maybe a specialist referral. You'll find some calcification in your coronary arteries. Well, yes, you're 68. You have some atherosclerosis. Most people your age do, but now you're terrified you're about to have a heart attack, even though that calcium score doesn't actually change your management if you're already doing the right things. A study published in JAMA examined outcomes from over 15,000 people who underwent full-body CT screening. More than 80% had at least one abnormal finding. Of those, fewer than 2% turned out to be clinically significant problems that actually required treatment. But more than 30% underwent invasive follow-up procedures, and 5% suffered complications from those procedures. Let me put that in perspective. For every one person who benefited from finding a real problem, 15 people were harmed by unnecessary follow-up. That's not good medicine. That's profitable medicine. These executive screening programs charge thousands of dollars and generate huge amounts of follow-up business for the healthcare system, but they rarely improve health outcomes for the individuals being screened. Here's the other insidious harm: the psychological burden. Once you know about every tiny abnormality in your body, you can't unknow it. You live with anxiety. You become hyper-focused on your health. You start feeling symptoms that might not even be real, just your mind's response to knowing something is wrong. The U.S. Preventive Services Task Force recommends against full-body CT screening in asymptomatic adults because the harms outweigh the benefits. Here's the pattern that should make you refuse this type of screening. You have no symptoms, you already get appropriate age-based screening like colonoscopy and mammography at reasonable intervals. You have a primary care doctor who knows you and your health history. And someone is trying to sell you a comprehensive scan package as an add-on or out-of-pocket service. That's not healthcare. That's a business transaction, and you're the product. Here's what you say when offered this. I appreciate the offer, but I'm going to stick with evidence-based screening recommended by my primary care doctor. If I develop symptoms, I'll address them at that time. You don't need to justify. You don't need to explain. Just decline. Here's what I need you to take away from this entire video. More testing is not always better medicine. After age 65, the goal of healthcare should shift from finding everything possible to maintaining quality of life and functional independence. That shift requires a completely different mindset. It requires you to ask different questions. It requires your doctor to think beyond the reflex to order tests and actually consider whether those tests will help you live better or just create medical problems where none existed before. Let me give you a framework for thinking about any screening test you're offered. Question 1. What specific outcome is this test trying to prevent or detect? If your doctor can't give you a clear answer beyond, "we're just being thorough," that's a red flag. Question 2. What is the likelihood that this test will find something that will actually change my treatment or improve my health? If the answer is vague or based on just-in-case thinking, the test probably isn't necessary. Question 3. What are the potential harms of this test, including follow-up procedures if something abnormal is found? Every test has downstream consequences. Make sure you understand them before you agree. Question 4. What happens if I don't do this test? What am I risking? Often the answer is very little. If that's the case, declining the test is a perfectly reasonable choice. Question 5. Is this test recommended by evidence-based guidelines for someone my age with my health status, or is this based on your personal practice pattern? This question separates guideline-based care from defensive medicine or habit-based practice. If your doctor gets defensive or dismissive when you ask these questions, that tells you something important. A good doctor will welcome these questions. A good doctor will respect your autonomy and help you make an informed decision. Now, here's what you should focus on instead of chasing screening tests. Focus on functional fitness. Can you get up from a chair without using your hands? Can you walk a mile without stopping? Can you carry your groceries? Those abilities predict your health and longevity far better than any screening test. Focus on fall prevention. More seniors die from complications of falls than from undetected cancers. Balance exercises, strength training, home safety modifications, these interventions have proven benefit. Focus on social connection. Loneliness and isolation increase mortality risk as much as smoking. Investing time in relationships and community involvement will do more for your health than another round of lab work. Focus on managing chronic conditions you already have. If you have diabetes, high blood pressure, or heart disease, optimizing management of those known problems is far more valuable than screening for hypothetical ones. Focus on symptoms. If something changes, if you develop new symptoms, absolutely get evaluated. But don't go looking for trouble when you feel fine. This approach isn't neglecting your health. It's prioritizing your health in ways that actually matter. Before we wrap up, I want to address something I know some of you are thinking right now. But Dr. Carter, my friend had a screening test that found cancer early and saved her life. Are you saying she shouldn't have gotten that test? No, I'm not saying that. Screening helps some people. Absolutely. The challenge is that we don't know in advance who will benefit and who will be harmed. So we have to look at populations and statistics. If 1,000 people get screened and one person benefits, but 600 people are harmed by unnecessary follow-up, was the screening program successful? From a public health standpoint, no. From the perspective of that one person whose cancer was caught early, absolutely yes. This is the fundamental tension in preventive medicine. It's why these decisions have to be individualized. It's why your values, your other health conditions, your personal risk tolerance, all of that matters. What I'm asking you to do is not reject all screening. I'm asking you to be thoughtful, to ask questions, to make sure any test you undergo is more likely to help than harm you specifically. And I'm asking you to give yourself permission to say no. You are allowed to decline tests. You are allowed to question recommendations. Your body, your choice. If this video gave you permission to question your healthcare instead of passively accepting every recommendation, hit that like button. Share this with someone you love who's over 65 and navigating the medical system. This perspective could save them from unnecessary procedures and help them age on their own terms. And subscribe to this channel right now, because next week I'm covering something equally important. 5 medications doctors prescribe too often after 60 and what to take instead. These are drugs sitting in your medicine cabinet right now that might be doing more harm than good. You'll want to catch that one. Until then, be an informed patient. Ask questions. Advocate for yourself. And remember, the goal isn't to live forever. The goal is to live well, on your terms, with your autonomy intact. I'm Dr. Michael Carter. I'll see you in the next one.